Dear colleagues, it's my pleasure to give you this talk, and thank you very much for this invitation. Conflicts and the context. As soon as pivotal trials, we could see that ischemic stroke under DOAC were slightly less frequent than under warfarin, by around 15%. This reduction was confirmed by the huge data from very big real-life registries for each of the DOAC. Despite this benefit, ischemic stroke under DOAC still represent a significant proportion of ischemic stroke associated with atrial fibrillation, up to 30% in this switch registry, 30%. So it's really a very common problem in the daily practice. Also, ischemic stroke under DOAC are not only less frequent, but also less severe than under VKA as a whole, and more specifically, the severity of stroke under DOAC are very similar to that under VKA, with INR higher than 1.7 at the acute phase as and the final outcome. But we have to keep in mind that all ischemic stroke occurring under DOAC are not cardioembolic. There is a significant proportion of competing mechanisms, about 25%, mainly atherothrombosis and small vessel disease, but also PFO, which is increasingly recognized as a common cause of ischemic stroke in elderly. In addition, there is an association between unjustified underdosage of DOAC and ischemic stroke, up to 15% in this study, but 45% in this other study. So we have absolutely avoided, because this greatly increases the ischemic risk. Now, how to give intravenous thrombolysis or thrombectomy for ischemic stroke under DOAC? We can see that as a whole, IVT is rarely given in patients under DOAC compared to patients under VKA. It's probably because it's more complex to deal with NOAC, whereas under VKA, the simple result of INR is sufficient to make the decision. For mechanical thrombectomy, conversely, the type of anticoagulant did not interact with the decision. I propose to you a decision-making algorithm for IVT in case of ischemic stroke under DOAC. And the first question is, it's a bit complex, but but the first question is the last taken of DOAC is less or more 48 hours? If more, IVT is allowed. If less, we must perform anticoagulant activity tests, unless the patient is under the bigatron, in which case we can give previously to IVT the antidote idarucizumab. Of course, if this antidote is available. The best specific anticoagulant tests are the specific dosage of DOAC. Below 50 nanograms per milliliter, IVT is allowed. But specific tests, specific dosage of DOAC are not widely available, so we have to fall back to non-specific tests in this case, as time of thrombin or 10A activity, or in a more usual way, PTT or ACG. But is it safe to propose IVT only on the basis of this basic test? Is it safe? We have several studies to give the answer, especially this one, in which a large subgroup of patients were given IVT on the basis of basic tests with normal or almost normal results. It's the middle line. And in this subgroup, there was no over-occurrence of symptomatic intracerebral hemorrhage compared to patients with a specific dosage or patients who received hydroxyzumab previously to IVT. So it's a crucial result to be applied widely in every center facing the situation. For mechanical thrombectomy, for patients with a large vessel intracranial occlusion, a meta-analysis showed that there is no safety concern with this procedure for patients under DOAC as in patients under VKA. So IVT is safe provided specific or non-specific tests are consistent with guidelines, and mechanical thrombectomy is safe whatever the type of anticoagulant. If no IVT, do we stop temporarily DOAC? A question, a big question. But in fact, we have a paucity of data on this topic. In this small retrospective study, anticoagulant was continued in a large subgroup of patients. But in these patients, the severity of stroke was very low compared to the severity in patients in whom anticoagulant was discontinued due to fear of bleeding. And what we see is that major bleeding events did not occur in the subgroup of patients in whom anticoagulant was continued with no recurrent ischemic stroke. So in minor stroke, it's probably safe not stopping anticoagulant NOAC as VKA. If nevertheless DOAC was temporarily stopped, when to resume DOAC? It's a crucial question because stroke patients with prior anticoagulation have a higher risk for an additional ischemic recurrent stroke. So to resume DOAC, we can follow the classical rule, 3, 6, 12 days, depending on the severity of the stroke. But due to the low risk of bleeding risk of DOAC, a less attentive strategy is currently assessed through 4 randomized clinical trials. One of them was recently published. It's the ELAN trial, who compared the classical strategy, 3, 6, 12, with a very early introduction on anticoagulation within 48 hours after a minor or moderate stroke, or in case of major stroke on day 6 or 7. The patients were equally distributed between the 3 severity levels that was representative of the real life. And what we see is that the study was positive in favor of early treatment for almost all the 8 points, with a tiny number of symptomatic intracranial hemorrhage, only 2, the same than in the later treatment. And the last question is, after an ischemic stroke under DOAC, do we switch for another anticoagulation or not? We have 2 large registry studies on this topic, very recent. In the first one, switching to another DOAC was neutral for recurrent ischemic stroke and maybe better for major cardiovascular event, whereas switching to DOAC, to VKA, was rather disastrous as much for hemorrhage as for recurrent ischemic stroke. In the second study, 70% of the patients were left under the same DOAC. And in patients in whom DOAC was switched for another DOAC, we see that it was not very good, contrary to the first study for ischemic stroke. We don't know exactly why. But we see that switching to warfarin was also very damaging, as much for hemorrhage as for ischemic stroke. It's really the main conclusion you have to draw from these two studies. In case of ischemic stroke under DOAC, do not change for VKA. Thank you very much.